Let's get right into it. Why do we worry about sleep? Well, we know sleep is linked to all kinds of health outcomes. So if you miss out on sleep, we know there are effects on your mental health, and that includes emotional difficulties. So things like symptoms of anxiety and depression. With prolonged sleep loss, we see even things like increased suicidality. And then also, in terms of behavioral manifestations, we see that people who don't sleep enough have difficulty with attention, with regulating their emotions. And so it really spans the whole sphere of mental health concerns. We know that there are daytime consequences to missing out on sleep. So people feel fatigued, they feel sleepy, they feel slowed mentally, like their brain just can't process information as well. For kids, this is really important because we know new memories and new learning can't take place if they haven't had enough sleep. There are physiological effects of missing out on sleep as well, and more we're finding links to cardiometabolic health. So we know that people who chronically don't sleep enough, they also are more likely to have things like hypertension, high cholesterol, impaired glucose tolerance, so higher risk of diabetes. And for the postpartum population, there are a number of studies that have shown that women who sleep less than others, so typically the cutoff is less than 6 hours of sleep, we know that they have greater postpartum weight retention that can contribute to overweight and obesity in the long term. Another physiological effect of sleep loss is that you have impaired immune function, so you're more susceptible to communicable diseases. And it impairs you get increased inflammation. So that's not good. That ties back to cardiometabolic health, but also, pain and things like that. We also see consequences of sleep loss in terms of risk-taking behavior. So we see more tobacco and alcohol use, and things like decision-making is impaired when you miss out on sleep. So your reaction times likely has an influence in the increased car accidents that we see among people who are chronically sleep deprived or acutely sleep deprived. Even things like unintentional injuries, trips and falls are increased amongst people who typically sleep less than 6 hours a night. So there's a whole host of reasons why sleep is super important for health. So I wanted to give you a look at what the National Sleep Foundation says are the amounts of sleep that are ideal. And so the deep blue bar represents at all these different ages what the recommended amount of sleep is. So for young adults, 18 to 25 years, and adults 26 to 64 years of age, you see somewhere between 7 and 9 hours a night is what's recommended. The greenish bars above and below indicate amounts of sleep that might be okay for someone in those age ranges.
Excuse me, Robyn.
Yeah.
Is your screen shared? Because I don't see the slide deck.
I wonder if it got unshared when
we moved around.
Yeah.
There you go.
Okay.
Good to go.
Sorry about that.
No,
it was
thank
working. I'm glad you said something. Okay, so here are those dark blue bars that I was talking about. And the greenish bars recommend, they're kind of in acknowledgement that there is a smaller proportion of the population that might need more sleep than that or less sleep than that. But really those long sleepers and short sleepers, as we call them in the sleep world, are more rare. And so for most people, somewhere between 7 and 9 hours is going to be about right. When you get into the yellow zone, that's really not recommended. So anything less than 6 and above 10 is probably indicating there might be some other health issues going on. So in terms of factors that affect infant and parental sleep, I've got a whole list here and we'll go through each one by one. But first off, it's really to say that you can't really talk about infant sleep without talking about parent sleep. They are linked together. You can't separate them out, of course. And it creates some interesting relationships that we'll take a look at later on, because it's not just the sleep itself or the number of minutes of sleep or the number of wakenings, but it's also the interactions between parent and infant that occur during the night that are really important. So we'll talk about that a little bit more. Of course, infant feeding method has an influence on sleep because infants are, at least in the first few months, they certainly are working on a 24-hour schedule that doesn't align with the circadian rhythm, the day-to-day rhythm of adults. And so those night wakings for feeding predominantly are really going to have an effect on sleep. Infant sleep location comes into play as well. So where is the infant sleeping? With the parents in a separate room. So we'll look at evidence around that as well. Infant health. So is this a full-term healthy infant or not? And how does that affect sleep? Napping for the adults in this infant's life. How does that influence their quality of sleep? Socioeconomic status and race has an influence. We can think of postpartum depression as an outcome or something that's acted on by infant and maternal sleep, but it can go the other direction as well. So there are effects of depression on infant and maternal outcomes. So we'll look at that as well. And then finally, who's in the family? What kind of support exists? These are all things that affect sleep. So first, let's talk about maternal sleep in the postpartum. While we know total nighttime sleep is decreased in the postpartum, and that's when I'm saying postpartum, usually I'm referring to the first year after the infant's arrival, we see the largest decreases in sleep efficiency. So yes, women are getting fewer minutes of sleep, but the biggest effect that we see is in how the sleep is organized. So sleep efficiency is the amount of time you're spending in bed relative to the number of minutes of sleep you're getting. And so sleep efficiency goes down for women in the postpartum because they are being woken up, but also because they're spending time awake after those awakenings. So no adult really sleeps through the night, but if we do have wakenings and we don't have an infant to look after, typically we're able to get back to sleep right away. So these wakes that occur are interrupting the woman's ability to move through the cycles of sleep that we want them to move through. So there are stages, 4 stages of non-rapid eye movement sleep, and that's really deep restorative sleep. And there's also REM sleep, which is where dreaming occurs, which is also a really important stage of sleep. So if women are getting woken up frequently, It's not letting them cycle through those deeper stages of sleep. So, a strategy for trying to maximize sleep is to talk to families about how they might lengthen the stretches of uninterrupted sleep that they might get. So, is there a way for partners to share the nighttime care so that um, sometimes they are getting those longer stretches of sleep? So then there's infant sleep and parents' responses to infant sleep. So, of course, infant care demands are the main reason why parents are up at night. But we also know that there are beliefs about ideas about ways of responding to the infant that can affect parents' sleep. So, a couple of years ago, we conducted a study. We interviewed almost 500 women. They were across Canada. We talked to them at 3 times during pregnancy and 1 time in the postpartum. And in the postpartum, we asked them about their cognitions around sleep. And so those were focused on doubt about how they managed their baby's sleep, any anger related to dealing with their infant sleep, and any fears or concerns about their infant's sleep or their infant's health during sleep. And what we found was that feelings of doubt around being able to manage their infant sleep was associated with increased checking on the infant. So actually going into the room and, sorry, I've got this thing popping up on my screen. Um, and, you know, seeing if the baby was okay outside of any actual infant care needs. And also, that doubt was associated with bed sharing, so having the baby sleep in the bed with them. Interestingly, those doubts about infant sleep also predicted depression in the moms and report of poor sleep quality. So we can see how there's this relationship, not just with the number of minutes of sleep, but also your feelings about your infant sleep. So it may be that strategies that help moms feel more confident about infant sleep could translate into improved sleep quality or perception, at least, of sleep quality in the postpartum. And it may have an influence over decisions that parents make around where their infant is sleeping as well. So it's important, I think, for clinicians to think about what are parents thinking about sleep? How comfortable are they with sleep, their infant sleep? And we'll talk about this a bit later on because I have another study that links sleep quality to depression. And so those two roots could be ways of exploring sleep and depression with parents. So what are parents thinking about infant sleep and their own sleep? How do they report their own sleep quality? Because that can give us some insight into their mental health. So then, infant feeding method. There are surprisingly few studies that have looked at infant feeding methods and maternal or parental sleep. But the ones that have either shown no difference in parental sleep. So it doesn't matter if you breastfeed or partially breastfeed or fully formula feed, or they've shown increased amounts of sleep for parents who have breastfed infants. So there's not a ton of information to go on. But I think the takeaway here can be that parents should know that there really isn't any evidence that supplementation is helpful. And I think that that's probably the most common, it's certainly a reason that families give, or often family members suggest to new parents who are struggling with sleep that maybe their choice of feeding method has something to do with it. And so I think this, although we don't have much information, the information that we have can be reassuring to parents that their choice of infant feeding, if they're choosing to breastfeed, is probably not related to any challenges they're having with infant sleep. So infant sleep location is one of those challenging issues for parents as well. I think certainly I've experienced in giving prenatal sessions at Mount Sinai that parents are very concerned about safe sleep. And so they are very concerned about where their infant is sleeping and the risks that may occur based on infant sleep location related to SIDS. And the advice around safe sleep doesn't exist in a vacuum. So families also have to take into account maybe their cultural background, what's been commonly done in their family by other family members, their choices around, sort of parenting philosophies, and how that might influence their choice of where their infant sleeps. But, we know that the Canadian Pediatric Society recommendations for safe sleep are that parents have the infant in the room with them for the first 6 months of the infant's life. And so I'm defining that as room sharing. So the infant is in the parent's room, but they're sleeping on a separate surface. And then we can also talk about bed sharing, where the infant is in the same bed as the parents or parent, or solitary sleeping. And so these three conditions are important for a study that I'm going to tell you about in a minute. We don't know very much about how these different sleep locations influence infant or parent sleep. There are very few studies. So I've conducted one of the only studies that has looked at this and has measured sleep using something called an actigraph. So it's like a Fitbit. It's a little device that measures motion, and then we're able to determine when babies and parents are asleep versus awake. So we took data from a study we did called the TIPS trial. And so we had data on 246 women and their infants. And we were able to group that data together and take a look at their infant sleep location plans and then what actually happened. So in the immediate postpartum, we asked women, where do you think your baby is going to sleep most of the time? And so you can see here, less than 5% thought that they would be bed sharing. And then we asked them again at 6 weeks and 12 weeks. These are the data about where the baby actually was usually sleeping. And you can see it's many more than the 5% who planned to usually bed share, who were bed sharing at 6 weeks and 12 weeks. So it's about 17% at 6 weeks and 12% at 12 weeks. So there have been some changes in plans, probably in response to, the real life experience of living with a eating, crying baby and responding to that. But we were interested in knowing, how do these categories translate? How do they affect the mom's sleep and the baby's sleep. So we looked at a number of different sleep variables, and the bolded numbers here are where we saw differences. So in general, we didn't see too many differences, except for moms who were bed sharing. You can see they had the shortest stretches of sleep at night. So the longest that they got at night was 130 minutes, compared to moms whose babies were room sharing or who were solitary sleeping in a separate room. So they got about 20 minutes to a half hour more sleep than the bed sharing moms. We also see that they had a significant number more wakes for the bed sharing group, so 11 wakes across the night as compared to 9 or 8 wakes for the room sharing and solitary sleeping babies. What's interesting to note here is that there were no differences in exclusive breastfeeding rates. So often there are concerns around especially solitary sleeping and its effects on breastfeeding, but we didn't see any differences here. So that's at 6 weeks. At 12 weeks, that issue related to breastfeeding holds. There are no differences across the groups depending on where the infant is sleeping. But we do see a difference in terms, again, of that longest stretch of sleep. We see it's the longest for the moms who are solitary sleeping. So bed sharing and room sharing are looking relatively the same, but a bit more sleep achieved for the solitary sleeping infants, families. So what's the takeaway for this? We can see that infant sleep location does have some effects on maternal sleep continuity, how long you can stay asleep before you're woken up. But it didn't seem to affect breastfeeding rates, and it didn't seem to affect the infant's sleep. So given that, parents were doing things differently than they had planned, it also seems that the parents' experiences with the infant along the first 6 weeks influenced the choice of infant sleep location. And that's probably related to their responses to infant feeding or crying or sleeping behaviors. And that probably shapes where the infant sleeps and breastfeeding success. So parents are probably working things out to achieve the goals that they want. So that paper is in the Open Sleep Journal if you have interest in looking at that further.
Robyn, can I just share a question that came up
Absolutely.
on chat? So someone asked about whether or not we should be discouraging bed sharing. Is that something that was addressed in your study? Did you guys give any specific advice around that?
No, we didn't give any specific advice. That study was really focused, that study was the TIPS trial. And we gave a package of intervention advice strategies around how to improve maternal sleep and infant sleep in the postpartum. We did not, though, give any advice related to infant sleep location. We were trying to be respectful of parents' choices around infant sleep and not influence that. And we really didn't have information about infant sleep location and infant or maternal sleep. So we did the study, and then we're able to examine those outcomes, but we didn't intervene within that study. Yeah. So I mentioned infant health, and infants born preterm or with medical conditions that might require hospitalization early in life have an influence on maternal sleep, certainly. So we'll talk about that in a minute. Our time is too limited today to talk about infant crying or colic, or dysregulated infants who may have significant issues with infant feeding, crying, and sleeping. So I'm going to leave them aside because I don't know that we have time to talk about that. But I think that, the baby admitted to NICU is a much more common occurrence. And so I wanted to share some work that one of my PhD students has done. Summer Haddad is an NICU nurse at Sick Kids. So this is really her area of interest. And she conducted a systematic review where she looked to the literature, gathered up all the studies that had looked at parent sleep, parents who had a preterm infant, both during the infant's hospitalization and after discharge. And, surprisingly, not too many studies looking at sleep for this really quite vulnerable group of parents. But of the studies that were conducted, one used actigraphy, that objective measure of sleep, and found that they were getting 6.3 hours of sleep a day in the first 5 to 10 days. So of course that would have been when the infant was still in hospital. Many more studies, 10 or so, reported poor subjective sleep quality. So that's the mother giving her own report of how well she thinks she's sleeping, and overall poor ratings from those moms. And then a number of the studies looked at, well, what is related to sleep quality? And overwhelmingly in those studies, they reported that as parent stress levels went up, sleep quality went down. So that paper was published just last year, if you want to take a look at that. So I'm extrapolating a little bit here, but one of the other areas in my program of research is sleep for parents who have a child in hospital. And I don't know if there are any NICU nurses in the crowd today, but I wanted to share some work that we've done looking at parents' experiences when they have a child in the PICU. And a large number, almost half of this group of 118 parents had an infant in the PICU. So a lot of cardiac surgery patients. But I wanted to share these data with you because I think it illustrates the struggles that parents do have when their child is hospitalized early in life. And this was a qualitative study where we asked parents about their sleep experiences, and they, really described a number of factors that influence their sleep. And one of the big struggles was trying to decide whether to stay at the bedside or to go home and to try and get some sleep. And this quote, I think, really describes how challenging that decision is for parents. And I suspect it's very similar to the NICU experience. Parents talked about how they had difficult thoughts and feelings. And I think often when infants are hospitalized, if there isn't a place for the parent to sleep in hospital, then the advice is to go home. But this parent's description that the nighttime is the hardest and she's lying there waiting for the phone to ring with bad news kind of illustrates that the sleep that they're getting at home may not be any better than they might get, in a waiting room chair. And then finally, a lot of bigger NICUs are moving towards having you know, family care rooms where the parent is able to stay, but that's not available everywhere. And so these two parents really describe the challenge of trying to find a place to sleep or wondering where they're going to sleep in an environment where, you know, there aren't many parent rooms available for them to stay. So I think the takeaways are, well, I mean, I could say the takeaway for all of these things is we need more research. But if you're in a center where you don't have facilities for parents to stay near their child, I think it's, you know, it's something that parents tell us really affects their sleep. So maybe that's something you can help advocate for. Just to know that telling parents go home, you know, get some sleep is maybe an oversimplification for them of how well they will sleep. And I think the other piece for this group who is already vulnerable, who is, we know, already at higher risk of postpartum mood disorders because of the stress of having a child who's ill and needs significant care at birth, is to have conversations with parents about the relationship between missing out on sleep and low mood and depression, and that working to maximize their sleep is going to help decrease the risk of postpartum depression. So we'll talk about that a bit more again in a few slides.
Robyn,
Yeah.
there are two questions. I don't know if this is a good point.
Sure.
One is back to the bed sharing question, and I don't know if at some point you could speak briefly about that, you know, sort of really strict directives to not bed share and the relationship to the risk of SIDS. I think there's always mixed information that is given, and I don't know if you can speak briefly to that. And then the other question is about melatonin. I don't know if you can see the chat box, but maybe start with the one and then I can read the other question.
Yeah, okay. Yeah, so I mean, Canadian Pediatric Society recommendations for sorry, I'm just muting. I want to go to whoever that little person is when I it's like
that time.
Speaking of maternal instincts and sleep. So Canadian Pediatric Society has clear guidelines in terms of recommendations for safe sleep. And those are focused on what are things parents can do to decrease the risk of SIDS. And it's a bit of a tricky area because any of the advice that we have, the guidelines given by CPS, they're all drawn from taking a look at, you know, these most unfortunate incidents where SIDS has led to an infant death, and taking a look at the circumstances around that infant's sleep situation. And so it's been found that infant deaths are more common, are more commonly situations where there has been bed sharing than not. And so that leads to that recommendation that bed sharing is to be avoided. The thing with these safe sleep recommendations is that there are also a number of recommendations on how you can reduce the risk of SIDS. And many parents are, you know, taking up these recommendations. So things like breastfeeding, we know breastfeeding reduces the risk of SIDS. Things like having a non-smoking home is going to reduce your risk of SIDS. And so it's this sort of difficult position for parents to take as a whole all of the recommendations and then think about other things that are important to them. So for some families, maybe they're practicing attachment parenting and it's really important for them to have closeness to the infant, and bed sharing is something that they want to do. Well, there may be ways that they are reducing their risk of SIDS, and they may be comfortable with the slightly increased risk of bed sharing. So, I mean, the guidelines from CPS are very clear. There are some documents, or there are other groups that have compiled advice on how, if families are choosing to bed share, how can they do that more safely? Things like ensuring there are not a lot of pillows or fluffy bedding in the bed that can lead to, covering the infant up, those kinds of things. So it's something that parents kind of have to work through the guidelines and take a look at what they're comfortable with. I hope I got
Thank you. I'm going to see if I can find a couple of those articles and maybe put them on our website.
So I mean, La Lesh League International is the one I'm sure that you're thinking of, Susan, that I'm thinking of.
Sure. Yeah.
That's really helpful for families who are thinking about bed sharing, how to do it the safest way possible.
Do you have the other question, or do you want me to read it to you? I can read it.
Yeah.
Okay. So there's a mom who's concerned with an 18-month-old who doesn't sleep all night, wakes up every 1 to 2 hours, very hyper during the daytime. What can the parents do? Dad is a police officer. Mom stays at home. Both are very tired. Recently, the baby was seen by a doctor and given melatonin. Do you have an opinion about the use of melatonin or any information? Or
yeah, I mean, the sleep clinicians I hang around would try and avoid use of melatonin in a healthy, typically developing child. Kids with autism, kids with other developmental disorders that may have effects on the brain's sort of sleep-wake regulatory system. I think most clinicians are pretty open to trying melatonin with those groups of kids. I think with a healthy, typically developing 18-month-old, most often the issues are behavioral, and there are usually a number of different strategies that can be looked at. So how are parents interacting with the child at bedtime? How regular are bedtimes and wake times? What's the sleep environment like? What's the bedtime routine like, and how consistent is it? What's the sleep environment like? How much light? How much activity is the child getting during the day? How much light exposure during the day? So there's a whole raft of strategies, which we will get to a little bit. I mean, the tips, strategies that we'll talk about later on are really targeted for the early postpartum, but the principles kind of apply even for toddlers. The other issue with 18-month-olds is they are starting to assert their independence and figure out what kinds of things they can do and what kinds of reactions they can get. So yeah, for me, melatonin would be something that comes after examining a lot of the other issues that I mentioned.
I just put up babysleep.com. I don't know if that would be a good place for perhaps these parents to take a look at.
Yeah, I think that's a great idea. Thanks, Susan. So babysleep.com is a website that I'm affiliated with. through the Pediatric Sleep Council. So it's a group of international sleep researchers and clinicians. We're led by Jody Mindell, who's in the US and who's really the infant and toddler sleep guru. And, we've all sort of contributed video clips that are answers to very common sleep questions. So that's a good place to start for sure.
I know there are a couple more questions, but I'm wondering if we should let you continue so we don't run too much out of time.
Yeah, well, I should keep an eye on the time here. Yeah. Oh gosh. Yeah.
Yeah. So why don't you continue, and then I'll keep these two questions. I'll bring them back.
Yeah, sure.
Is that okay?
Sure. Yeah, okay. Perfect. Okay. So napping. I mean, this is the age-old advice that people get, right? Sleep when the baby sleeps. Well, it sounds great in theory. Is there any evidence that that is helpful? Actually, no. And the evidence that we have is that women really aren't napping that much. So, it's kind of less than once a week on average. And when they do nap, it's pretty short. So, I think any of us who have had small babies at home know that there are lots of dependencies on whether you can get a nap or not. So it depends on your family composition. Are there other kids at home? Are there other caregivers who can watch those kids or give you, the support you need while you take a nap? And truly, I don't know if this is the best advice, because really human adults are designed to sleep at night. So, saying sleep when the baby sleeps implies that you're doing a fair bit of sleep during the day, and that's just not how adult sleep is best designed to happen. So it's probably not the perfect advice we'd like it to be. What I can tell you though is that a brief nap, if a parent is feeling really tired, really run down, even just a brief nap, power nap, can be really restorative and can increase cognitive function and increase mood, give you a little bit of a lift. You want to be careful to keep it less than 20 minutes though. If you go longer than that, you run the risk of getting into the deeper stages of sleep. And then we've all had a nap that went a bit too long and you wake up feeling groggy. We call that sleep inertia. If you keep your nap short, under 20 minutes, it'll be refreshing, but you won't feel groggy. Sorry, just having trouble moving there. So socioeconomic status and race are two other really important factors to consider when we're talking about sleep. We know across the board, all kinds of populations, not just postpartum women, racial persons who are racialized with low socioeconomic status have less sleep time. They achieve less sleep. A greater proportion of racialized communities are sleep deprived compared with Caucasian communities. And so this is consistent across many, many studies. The hypothesis is that exposure to chronic stress, racism, creates these difficulties with sleep. And so it's something for nurses to be aware of, that families with, who struggle with adequate income, families in racialized groups are going to experience even greater sleep deprivation than non-racialized groups, than higher income bracket groups. And I guess, the good news is that there's evidence that some of the interventions that are out there targeting sleep may be most beneficial to these groups. And I think there needs to be more research in that area. Okay, postpartum depression. I've alluded to this a little bit. There's a very large body of evidence showing that sleep deprivation is associated with mood disorders. So we see reductions in sleep quality during pregnancy and postpartum, and even perception of problematic infant sleep are associated with postpartum depression. So these are really strong relationships, and lots of studies showing the same direction of relationship. So in terms of takeaways for your practice as a nurse, if you're hearing from parents that they're not getting a lot of sleep, or they're complaining of really poor sleep quality, really fragmented sleep, lots of awakenings, or having trouble falling back asleep once they've been up with the infant, or if you have a mom who's coming in and saying, you know, there's something wrong with my baby's sleep, my baby's not sleeping enough, this can be an important indicator of low mood. So it's something to pay attention to beyond just the sleep issues that they're raising. The second takeaway is that asking about sleep can be used as a less stigmatized, less threatening way of exploring mood with the family. And, you know, you can simply ask, you know, how is your sleep? Is it no problem at all, a little problem, a big problem? And it's that big problem category, whether mom's describing her own sleep or her infant's sleep as a big problem, that might prompt you to look a little bit deeper. And so we've seen these relationships in looking at our own data on sleep, again, from the TIPS trial. So we found these relationships expressed quite strongly.
Robyn, I just want to ask a question because it relates to what you just said. And Cassandra's asked, could you elaborate on perception of problematic infant sleep? Do you mean reduced sleep? Mothers are not seeing that there are issues with infant sleep, ? So,
yeah, so we, in the study I've got pasted up there, we asked moms, how is your baby's sleep? And then the responses were, it's no problem at all, it's a small problem, or it's a big problem. So you can really break it down in quite a simple way. We didn't define, you know, the nature of the problem. We didn't ask them to report, you know, how many hours a night they were sleeping or how many awakenings. And I think that's really important to let the mom define what a problem is, because it also opens up the conversation for you to explore that. Are her expectations around sleep realistic or not? So I think it's important to stay broad and not try and define sleep problems from a very clinical perspective, but to use it as an opening to explore what the mom thinks about them.
Great, thank you.
Okay. We talked a bit about the importance of who's in your family and who's supporting you. We've got lots of evidence that first-time parents experience greater sleep reductions, so less sleep duration and lower sleep quality than parents who are having their second and third, etc. Something that's interesting, Liat Tukotsky is in Israel, and she did this study looking at how much time dads spent caring for their child at a number of different time points. And she showed that early on at 3 months, how involved the dad is actually predicts better mom sleep and baby sleep at 6 months. So I think that's kind of an interesting takeaway that we can reflect back to partners. I think, you know, sometimes partners need a bit of a boost, that there is actually evidence that what they are doing can be helpful. Unfortunately, there are very few studies looking at dads and partners' experiences in general. The ones that exist have actually shown that dads often get less sleep than moms, and experience more daytime sleepiness than moms, which has implications for doing things like driving or operating machinery, that kind of thing. And again, that relationship between sleep loss and depression, depressive symptoms holds, even if you aren't the partner who gave birth. So this is a hot off the press review that's looked at fathers. So there's much more interest in looking at family members beyond just the mom who gave birth.
I'm going to ask two questions that just fit right in here, and I'll just read them out. So Jasmine asked, does having extended family helping out with the baby significantly increase maternal sleep? I don't know if that fits in.
Yeah. I mean, it's a great question. I don't know of anyone who has actually examined that in a research study. It makes good sense that, if you've got more instrumental support around you, that it should be helpful. But I don't know anyone who's looked at that.
Okay, the other question is a question around whether the Canadian Pediatric Society findings around SIDS broke down, risk factors between the differences between one parent and a baby and two parents and a baby. Does that make sense? So again, about...
Yeah, so I think asking, is there greater risk conferred if there are two adults in the bed as opposed to one?
Yeah, I don't know if it's specific to bed sharing, but it might be. I don't know, Sharon, if you want to add anything to it. Go ahead.
Yes, it was specific to bed sharing.
Okay, thank you.
Yeah.
Yeah, so I don't think they distinguish between mom versus mom and dad. They do make a clarification, I think, in the CPS guidelines that sharing a bed with an adult who isn't a parent of the infant confers a greater risk for SIDS. But I don't think whether it's one or two parents in the bed, I don't think that is called out as an additional risk factor. Certainly if either parent is impaired in any way through alcohol or drugs, that's called out as a risk factor. And if it's a non-parental adult, that is mentioned for sure.
Good, thanks.
Okay. Yeah, so we talked about engaging partners, letting them know their influence counts. I also think it's really important, given that we know partners are missing out on sleep too, that they get, the same sleep education that the mom who gave birth is receiving. And I think, if you have partners together at any time, it's an opportunity to encourage them to have a discussion around the link between sleep loss and mental health outcomes. So I think it's really important for couples to talk about how they're each affected by sleep loss. Some are more resilient than others. And, knowing that there are links to low mood, what would the other partner do if they see, or are concerned about depressive symptoms in their partner? So to have that discussion before those symptoms appear, I think it's really helpful to get people thinking about, you know, what resources would you mobilize? Who would you talk to? Where would you go? And then they've both talked about the plan before the plan. Hopefully it doesn't become necessary, but if it does, they've had that conversation and done that thinking beforehand. So, Susan, what do you think? I have some slides about interventions, but I know it's 8:17. We've been sort of taking questions. I don't know if you want me to.
I think people have been pretty good at putting the questions in chat.
Okay.
I do want to just say there is a question here that I've been waiting to just, let me bring it up now.
Yeah.
So Tamara has asked about the SNU bassinets. That
Yes.
There's lots of talk on social media, and she's curious if this is something that you have looked into or the apps that link to infant sleep.
Right. So the SNU was developed by Dr. Harvey Karp, who is the author of The Happiest Baby on the Block. So you might know that very popular baby book. And he talks about the 5 S's. It's a really helpful book for parents to gain some strategies around how to settle an infant who's full on crying, who you need to just kind of bring down a little bit so that they can better transition to sleep. And so he's taken his theory and tried to translate it into a crib. It's quite an expensive crib, so I think it's something that's really only accessible to upper income families. But it acts on the notion that when the baby starts to cry in the bassinet, they start to cry. That enables some white noise and some motion. So the bassinet starts to move, to rock the infant. There hasn't been anything published yet. I know that he does have some researchers working on studies, and you know, the theory is sound about you know, those strategies being helpful in settling infants, but there's, you know, the way to test this is to do a randomized control trial. So a group of families get the SNU, a group of families don't, and then you want to measure sleep in both groups. So that evidence isn't out there yet.
Thank you.
Okay.
I don't do whatever you think works.
Okay, well, I'll try and do a few more slides yeah. So I just wanted to raise this as one of the challenges in making a difference in maternal and infant sleep is that in some ways we've kind of gotten to a position where we just expect sleep to be bad in pregnancy, during labor and delivery, and in postpartum. And so in some ways, I think there's a little bit of shoulder shrugging. We kind of think, well, you know, this is kind of what you're in for. And I think that is partly why we see really low rates of help seeking around sleep from women, and not a lot of assessment by care providers. So not a lot of asking families about sleep. And in our sleep time study, where we talked to almost 500 women across Canada, in fact, fewer than 10% of the women we talked to had asked a healthcare provider about sleep, and similarly low numbers had been asked about their sleep by their healthcare provider. So I just wanted to flag that as somewhere that we can make a difference, that we should be trying to be proactive in asking about families' sleep. So I put these together. This is the first time I'm calling this Stremler's Sleep Manifesto, so I'm not sure if I'm going to stick with that title. But I guess these are kind of my philosophies around sleep that I try to carry with me when I'm working with families around sleep. I just really want them to walk away knowing that sleep shouldn't be a competitive sport. In some ways, it can get that way. A lot of people ask you, how's your baby sleeping? Or is your baby sleeping through the night yet? And so I think parents get together and there's a lot of conversations about that. I think, I'm a researcher. I think research is really helpful for understanding what the best approaches are, but ultimately families have to do what they are comfortable with. And I, as a researcher and a clinician, am not comfortable with telling people what they must do. So they need to make choices around sleep that work best for their family. And I also like to try and nudge people towards the thinking that we're not good sleepers or bad sleepers, that sleep is a behavior that can be changed. And it's hard work to change your sleep. And so you need to take it easy on yourself. Take it one night at a time when you're trying to make changes. So in terms of changes, there are a few intervention studies that have been done. Those that have looked at sleep in the early postpartum and tried to shape either infant sleep or maternal sleep are really appreciated by families. They might report subjectively that the strategies were helpful and that they feel like sleep is less of a problem. But when we measure sleep objectively, we don't see big differences. However, I mentioned earlier that these strategies may be more helpful for less advantaged families, because there are a couple of studies that have shown some difference in lower socioeconomic and racialized groups. Interventions that come later after the infant is 6 months old. So those are typically aimed at decreasing feeding at night when feeding is no longer necessary and waking at night. Those we do see differences. We see increases in maternal sleep, ratings of quality, and decreased rates of postpartum depression when we can make changes to infant sleep. And so that raises the issue of sleep training. And so if we have time, we'll talk about that. I've mentioned the TIPS trial a couple of times. And so that was a study funded by the Canadian Institutes of Health Research, where we recruited 246 moms who were healthy and they had a healthy full-term infant. And the intervention was meeting with a nurse, discussing tips to improve their sleep and their baby's sleep. And you can access the booklet that we gave to moms via my website, which is stremlerresearch.com. And we also gave some follow-up phone calls to moms. And so we met with them on the postpartum unit, and then we wanted to know, did they use those strategies and did it make a difference at 6 weeks and 12 weeks postpartum in terms of their sleep and depression and breastfeeding, those kinds of things. So we had done a pilot of this intervention. It's published here. You can see the paper there. And we found that women who did the TIPS intervention got almost an hour more sleep and their babies slept for longer stretches. So that's when we got money to do the bigger trial. We did see a difference in the bigger trial. The number of women who reported their sleep was a big problem. So many more women, 14% in the control group, said their sleep was a big problem compared to only 2% in the TIPS intervention group. But we didn't see any differences on those more objectively measured outcomes. Women liked being in the study. They liked keeping a sleep diary, and that's a nice intervention that you can try with the families you work with. Having them sort of plot out when the infant is sleeping in itself can be a bit of an intervention. So as I said, these strategies may be more of kind of a smorgasbord of tips that people can choose from. And that on the right is what the little booklet looks like, that you can access for free on my website. And the paper was published in the British Medical Journal, so you can check that out as well. I've got a whole, I've sort of got a whole raft of slides here that go over the information that's in the tips booklet. So I won't go through that. I will show you that's what the babysleep.com website looks like. And I can talk about sleep training if there are questions about that, but maybe I will just end with leaving these sort of final thoughts about things that you might want to explore with families, just to get them thinking about sleep. Who's on their team? Who do they need to have conversations about sleep with? How hard is it for you to hear your baby cry? What kind of strategies do you think you'll use? How do you each react to missing out on sleep, and how can you support each other when that inevitably happens? And how do you kind of plan to keep each other going when the going gets tough? I think are all really good conversations to encourage families to have together.
That's great. Okay, thank you so much, Robyn. I know there's only 2 minutes left, and I'm not sure if our webinar just shuts down right on time.
I don't think it should.
Okay.
I'm happy to stick around, so.
Okay, there is, Kim has asked if you could mention briefly about sleep training. I don't know if you have sort of a little, I don't know, brief sort of summary of,
Yeah.
share.
Yeah. So I guess probably this slide will sum it up as much as I can. Again, the sleep folks that I hang around with generally agree sleep training shouldn't be started before 6 months. And that's to make sure feeding is going well and that attachment is strong. Most of the sleep training methods require some separation and some stress for the infant. And so we really want to be sure that parent and infant are well attached. The idea behind sleep training is that you're trying to eliminate any sleep associations that have developed. So it's anything that has become linked to the infant falling asleep that likely needs to be recreated anytime the infant wakes up again. And so often that is feeding. Sometimes though, it's just parental closeness. Maybe there's rocking, jiggling, in a rocking chair. Some kind of behaviors that help the infant fall asleep, but when they wake up out of a very, briefly, but out of a sleep cycle, as we all do across the night, they need those conditions recreated for them to fall asleep again. And so sleep training is really just trying to eliminate those. And there are two approaches you can take. One is the rip the Band-Aid off approach. And you might have heard it called the cry it out approach, or graduated extinction, or checking in. But the idea is you leave the infant and leave the room, reassure them they're fine, but leave the room for 5 minutes. There will be a lot of protestation. You go back in, reassure them you're there, but no picking them up. Back out again for 10. Go until you're out 15 minutes and stay out. So it's effective, it's quick if it is done consistently. And that is the tricky part, that parents really have to apply themselves and not pick the baby up, not go back in. So that doesn't work for everyone. Not everyone can handle the crying. And so there's a gentler approach, but it usually takes longer. And in that case, you're slowly withdrawing yourself from the procedures of falling asleep. So if you're sitting in a chair, holding the baby, rubbing their back in a rocking chair, you pick one of those elements to remove. So maybe you're not rocking anymore, you're just holding them. After a few days, then you remove something else. You're not patting and jiggling and singing a song. And so you gradually try and move yourself so that the infant is in the crib. Maybe you're just rubbing their back, and then you gradually move yourself out towards the door. For either of those approaches, though, for sleep training to happen, ideally you're not having a number of feeds at night. So if feeding is the association, that really needs to be removed first before you can try either of those approaches. That's a very quick and dirty. Okay.
No, it's very helpful. Thank you. I don't see any more questions. There's lots of thanks for the evening, and it was wonderful, Robyn. Thank you.
Right.
I'm sure it was very helpful, and there may be some resources that I can put up on our Facebook page, and I've put in some links, so I'm sure people have really benefited.
Great.
So thank
No,
you
it's
so
my
much
pleasure.
for doing that. All right. And I will, I'll get the recording, and so if you want it, Robyn, I can pass it on to you, and we'll set it up on our website.
Yeah,
as well.
perfect.
Okay.
Thanks.
Thanks. Good night, everybody. Thank you all for being here with
Night.
us. Take care. Okay. Good night.
Sharon. I'm looking at Sharon Adams' name.
Oh, yeah.
How many were there at the
We
max?
had 38.
Okay. Just
Yeah.
like to know.
That was good. Oh, yeah. Lots of good questions, and
Great.
lots of things I'm thinking, oh, I need to put that in my prenatal class.
Yeah.
It's such a good topic.
Good. Yeah, it was well, it went by so fast compared to the 3-hour
I know, but you know what?
prenatal
It
class.
felt like, yeah, but it felt like you got lots in
Okay,
there.
good.
And I think in the prenatal class, I think you get interrupted a lot more. I don't
yes.
know.
Yeah.
That's true.
True. Great. Okay.
That's great. All right. Take care. I'll talk soon.
Okay. Take care. Bye.
Okay. Bye.